In this session, I'm delighted to share an example from Thailand where PEPFAR, in coordination with Ministry of Public Health, Thai AIDS Society, and several other partners, have worked to support it. We have supported pediatric dolutegravir policy and implementation in Thailand since the year 2021. World Health Organization recommends dolutegravir as the preferred first-line antiretroviral treatment regimen for adults, adolescents, and children. Transition to dolutegravir for children will harmonize with adult treatment, higher genetic barrier of resistance, minimal side effects, improved adherence, and lower pediatric treatment costs over other regimens, and make the best available regimen accessible to children in order to improve treatment experience and outcomes. This slide highlights 5 critical steps required to develop, adopt, and implement pediatric dolutegravir in Thailand. The first step was the revision of the National HIV Treatment and Care Guidelines to include pediatric dolutegravir-based regimen in the first-line drug. By reviewing the status of the antiretroviral regimens for children living with HIV in Thailand and treatment outcomes, we were able to identify gaps. And we review of patent issues and medicine patent pool agreements for using of the pediatric DTG in Thailand. The second step was related to regulatory and registrations. Before we were able to explore options for drug access and develop training and materials and tools for implementation and procure and deliver the drugs into the national AIDS program and health facilities. Dolutegravir is recommended as the preferred first and second-line treatment regimen in our children, adolescents, and adults in Thailand in the National Guideline 2021 to 2022. And Thailand started TLD or tenofovir lamivudine dolutegravir transition among newly diagnosed patients in January 2022 and among all people living with HIV/AIDS in June 2022. By September this year, you can see on the graph on the right-hand side, 87% of newly diagnosed patients received TLD in Thailand, and 50% on the left-hand side are people living with HIV currently on treatment, 50% of them receive TLD. When we look at the percent of the TLD and percent dolutegravir-based regimen distribution by age group, you can, among the people living with HIV on treatment in blue graph on the left-hand side, and among newly diagnosed people living with HIV in pink on the right-hand side, you can see that children below 5 years old had low uptake of dolutegravir in Thailand. And this slide shows you World Health Organization recommended dosing for abacavir 3TC and dolutegravir formulations. Although dolutegravir 10 milligram is recommended by World Health Organization for children at least 3 kilograms up to 20 kilograms, and as well as other preferred regimen to implement for all children in Thailand. However, in the graph, you can see that abacavir 3TC and dolutegravir dispersible tablets are still not available in Thailand. Fortunately, we have abacavir 3TC tablet and dolutegravir tablets for children weighing 20 kilograms and at least 20 kilograms. And also we also have TLD for children weighing 30 kilograms or more. In this graph, you can see in the National AIDS Program in Thailand, we have only Cydoverine syrup, lamivudine, nevirapine, and lopinavir/ritonavir syrup. We don't have lopinavir/ritonavir pellets in the National AIDS Program for young children. For older children and adults, we have tablets of dolutegravir, TLD, efavirenz, abacavir 3TC, ACT 3TC, ripivirine, darunavir, and atazanavir in the National AIDS Program. In the graph, you can see that for children aged less than 1 year, 100% of them receive lopinavir/ritonavir-based regimen in blue blue color. And for 1 to 4 years, 70% of them received lopinavir ritonavir, followed by dolutegravir in green and efference. And for 5 to 9 years old, about 40% of them received lopinavir-based regimen, followed by efference and dolutegravir. Percent viral load coverage among people living with HIV in Thailand in 2022 was 89% with very high viral load suppression of 97%. On the right-hand side, you can see that the viral load suppression rate among children and adolescents in Thailand were lower than adults. And when looking at the data for those who aged less than 15 years old, only 89% of them had virological suppression compared to 97% in adults that have virological suppression. This graph shows you percent viral load testing and viral load suppression in children less than 15 years. This aggregated by age group. And you can see that above the graph, children aged less than 5 years had lower viral load suppression rate compared to other group of children. And among those who 1 to 4 years, only 78% of them had virological suppression less than 1,000 copies per ml, and only 63% had virologic suppressed less than 50 copies per ml. The viral load suppression is even lower among HIV-positive infants. In this diagram shows you treatment outcomes of HIV-infected infants that presented at the AIDS conference in 2016. Although this data is old, but the main regimen that we use in Thailand still be the same regimen, that is the lopinavir ritonavir syrup. And from this data, I'm sharing this data because a larger number of the sample in Thailand for young infants. In this graph, you can see that 101 HIV-infected infants, of these, 85% of them received antiretroviral treatment, and mainly lopinavir ritonavir-based regimen, about 90%. And 68% of them had virological suppression less than 1,000 copies per ml at 12 months after ART initiation. As mentioned earlier in previous slides, you can see that in Thailand, small children receive lopinavir ritonavir-based regimen as their main regimen, and this created some obstacles in preventing them from good adherence. For example, poor palatability, regimen complexity, need require twice daily dosing, issues for swallowing of the medications, and lopinavir ritonavir also required to have a cold chain storage. That means at the hospital, and for patients, they need to have a refrigerator in order to store the medications. And pediatric dispersible tablet may help solve these issues. So the National AIDS Working Group, Pediatric Working Group, they reviewed the national data and also estimated number of pediatric the number of children living with HIV weighing less than 20 kilograms in order to identify who would benefit from using pediatric DTG. And from this slide, as Annette mentioned earlier, number of children and adolescents living with HIV has been declining in all age groups in Thailand over the past 2 years. And this is as a result of a successful mother-to-child transmission program in Thailand, preventing mother-to-child transmission program in Thailand. Thailand received EMTCT validation by World Health Organization in 2016, and with their mother-to-child transmission rate less than 2%. And we estimated about 200 children living with HIV aged less than 5 years, and estimated about 400 children weighing less than 20 kilograms in 2022. The working group also reviewed the medicines patent pool agreement from WIF and check whether Thailand was included on the country list that could use the low cost version of the pediatric DTG. And here you see our countries that received in the medical patent pool agreement list, including 31 countries in Asia, and Thailand is on the right lower column and side. Next step was that we work with the local manufacturers to apply their pediatric DTG filing to Thai FDA. And 2 companies applied the pediatric DTG 5 milligrams with and 10 milligrams from Mylan to the Thai FDA in July 2021, and 1 company, 5 milligram, received approval recently in the last few months. And generic dolutegravir and generic TLD was approved by Thai FDA in 2021 and became available in the National AIDS Program in 2022. This shows you some examples of information that we enclose in the package that submit to the Thai FDA for approval. You can see that we have to prepare a lot of documents in order to get approval, registration for pediatric DTG in Thailand that include pediatric HIV statistics, treatment outcomes in Thailand, why we need the pediatric-friendly formulation, update guidelines, and voluntary licensing of the pediatric DTG MPP agreement, as well as information from the WHO model list of essential medicines for children in terms of the benefits, safety, cost effectiveness, and indication, dosage, as well as clinical studies conducted in Thailand, including PK studies in Thai children. This slide shows you a process for pediatric DTG registration from submitting the pediatric DTG filing package to the Thai FDA until the drug availability in the NAP system. Best case scenario would take about 1 year. Under the best case scenario, the national working group led by the Ministry of Public Health needs to communicate with Thai FDA to get the fast-track registration for the drug. And they also need to communicate with the National Essential Drug List Committee in advance that we will submit pediatric DTG as a supplemental formulation of previously approved DTG. And also discuss with the National Health Security Office and Thai government pharmaceutical organization to plan for procure and deliver drugs into the system, NAP system. If any of the steps are delayed, the worst case scenario for making pediatric DTG availability in the NAP system may take about 2 years. And because the process that I mentioned earlier is taking so long, so the pediatric working group explore other options for early drug access. So we discussed with potential donors such as WIF, PEPFAR, Global Funds for Pediatric DTG donation. And finally, the Ministry of Public Health received budget donation from Global Funds to procure the drugs for about 400 children. And as mentioned earlier, as we wait for the expedited process of the registration to be finalized during this period, the government received donation from Global Funds, and the MOPH anticipates that the drug will be available in April this year. That is good news. And this drug will be available for 1 year after we transition to pediatric DTG buying using the government budget in the NAP system. During this period, we've been working with the government, everyone in the working group, been working with the government to prepare for the national training for information, education, communication materials, as well as to prepare for procurement and delivery with the Thai government, pharmaceutical company, and Ministry of Public Health and National Health Security Office. This slide shows you that we have prepared some training materials, job aids for healthcare providers to use that already published last year. And we also have prepared on the dashboard monitoring to use for quality improvement in order to ensure that once the drug is available, we can smooth transition of the pediatric DTG use in Thailand. In conclusions, current ARV formulations of pediatric HIV treatment in Thailand are limited, and mainly we use lopinavir-ritonavir-based regimen for young children. And we as demonstrated earlier, children and adolescents living with HIV in Thailand had worse treatment outcomes compared to adults, and we face implementation challenges when adopting the new WHO guidelines, as there are several steps for policy and implementation timeline for any registration drugs. And multiple partners are committed to work together to successfully transition to optimal regimens, such as expedited the process for registration, exploring other options for drug donation, and good news is that we will have drug available hopefully in April this year. And as Annette mentioned, in terms of the procurement drugs in low volume and distribution of the ARV drugs, transition to new drugs in the NAP system require strong coordination across government, technical working groups, and procurement agency, as well as from the program managers. So it needs a huge effort in order to register the drug successfully. And I'd like to acknowledge the following partners for their support of the pediatric DTG policy and implementation in Thailand and for the slide presentation. And thank you very much for your attention, and I'm happy to answer any questions you may have. Thank you.